Oh, we're online. Good morning, Kyiv, or good afternoon.
Good afternoon, Chris.
It's a pleasure. Professor Regula did do it single-handed. I do more and more it with a nurse, and I'll explain you a little bit why. I was trained to do it on my own. Especially, you heard already about rotating, the looping and everything. But what I see now in our country is with very good trained nurses, we think we speed up the whole thing. And in the logistic approach, we are doing the screening colonoscopies half an hour. In the past, we were doing 45 minutes. I've performed in my life probably 30,000 colonoscopies. So I can do it single-handed. The whole thing is maybe good for the audience to know. In the past we learned to scope with our left hand, and the scope was designed that you could rotate with your right hand. So nobody realized when we started this in, let's say, in the 70s, even before my time, that you could rotate the scope like this and do the, with your thumb, your large wheel like that. So you rarely use the small rotator because you do it like that. And with the rotation, you can do the whole thing. If we now back home in my unit with the nurses, the nurse, even without talking with each other, she or he is rotating the scope, bringing back, pulling in, or telling me you have to turn the patient. So I think with this approach, we work a little bit faster. In case of the polyp, and Jaroslav was mentioning that, for the cold snare, if there's very small polyps, the nurse is doing everything. When the polyp is a little bit larger, I do it because I want to have the feeling. Okay, we can start. Then another thing is, I always prefer to have the scope on the table, because if you leave it down there, it's more difficult to rotate. So the quality is better when you put it on the table. Okay, let's have a look. And you see, my nurse is working with me for the first time, so this is, you can go in a little bit. So normally when I do it home, my nurse is bringing in the scope, and this nurse is also doing it. I don't have to say her anything because she's well experienced, and she will stop when she doesn't see an opening. And that's the trick. If you do it with a nurse, then I can concentrate. I do it, if you look to my hands, I do it like this. But if the nurse is there, and especially if the colon is a diverticular colon, like we see a lot in the Netherlands with obese population, I prefer sometimes. So now the nurse is, because she doesn't know me that much, and I'm now looking where the opening is, and I have to come up, go very, very slow. So you see, this is different, but I thought it would be good to show you. So here at 11 o'clock, I have to work here. And now up probably to 2 o'clock, a little bit back. Live demonstration is so nice because you always are in a different situation than home with different people. I love this scope. I work in our unit. We have a combination of Fuji and Olympus, But in general, these scopes, these new Olympus scopes, come on, yes, you can go on. Very slow, come on, come on. Yes, come in. You can go inside. Now I help her for a moment, because, and this is also, we were talking about nurse endoscopists. And I think in training, if you want to do this, and there's a lot of politics that people say we don't want to start our nurses with endoscopy, but I think a nurse like here, she is head of the unit or chief nurse here, she is probably so experienced, she has seen so much endoscopies that if those nurses are working with a junior doctor, they, as a matter of fact, train the doctor more than the chief endoscopist, because he is doing other things. So I think if you make benefit of nurses in the future, it would help. It would help. But I realize also the politics. You have a complicated system here in Ukraine with still endoscopists, surgeons, and gastroenterologists who, in general, I have now to. There's a. Can we have some water here? Oh, yes. Is this water? Yes. Okay. You have now, that's also not mentioned here, you have a guy named Saud Ishak in Birmingham, and he is now chairman of the underwater endoscopists in Europe, and he had a fantastic session at UEG on Monday, this Monday. And what he is saying is that if you have some kinking or some fluid too much, well, yes, beautiful, beautiful. So wait a moment here. Like you saw my kinking here for a moment, and sometimes with some fluid still there, you don't know exactly where to go. And his technique is bringing in 100, 200, 300 cc fluid to know a little bit better where to go. And I think especially in obese patients, in patients with diverticular disease, that helps a lot. Let's have a look where to go. I think I have to go upstairs here, so to say, very slow. Yes. So again, this lady is, well, she is reasonably prepared. I don't, but if you bring in extra water while you're suctioning, you can open the colon a little bit easier. So this is one of the things for the underwater endoscopy. And also for small polyps, when you want to be sure that you don't do a transmural resection, underwater might help. But that's a different trick. Okay, you can come in. This is not the water I brought in. It was there already. Okay, you can go in. Oh, sorry. Come on. The scope is fantastic. I really like this scope. Do we have to say something about this? Do you use this?
Sometimes, but not so often.
Yeah. So I think this straighter of Olympus is a fantastic invention, but I have to say, in normal life, I rarely use it. I rarely use it. And probably the more experienced you are, the less you need this. No. Let's have a look. I have to go here to the left, I think. I bring in again some water. If I don't make progress, in general, of course, you can turn the patients on the back. I like, if I use the underwater technique, if I don't make progress anymore in the difficult colonoscopies, I put the patients on their right side and bring in, let's say, half a liter of water. Then I take out the kinking of the colon. This colon is, I don't excuse me for this colon, but let's say a really difficult colon. And by doing that, you bring out the kinking very smoothly, very easy. So I like that. Now we start to suction. Jaroslav was also talking about you have to suction, to suction, to suction, to shorten the colon. And that's one of those very important tricks. And of course, if you don't have access back home to CO2 influction, that's one of the cheapest thing for you in your hospital to improve your quality. Because if you don't have that, you, no, the position is still, well, I check now for a moment if my position is a short position, and it's reasonable short, and you can see it. Can we do it like that? If, yeah, my position is good otherwise. So you check it, how short you are, and then we make progress again. No, I'm still have, the position is I think the valve is coming there already. So now we have to press a little bit there. Yes, a little bit. And this is also very nice to see, because in my own unit, where the nurses know how I would react, they would have done this already a few minutes ago. Okay, we're already in the cecum, but it's a little bit dirt here. The problem is, it's not this lady, because the lady is skinny enough, but you will face also here in Ukraine a lot of obese patients. Let's say upper class is probably not very obese, but the lower, the blue collars, as they eat in general too much fat and the whole thing, you will face more difficult colonoscopies to obese patients, and you have to realize this. This patient otherwise has a negative history, but she had a gynecological surgery last year. But okay, the pelvic floor and otherwise is not hampered by that, so we have to clean a little bit. Based on the program, I don't know if it's mandatory for the audience to see my pulling back. I don't expect that much. And maybe for the program that you don't delay too much, we can go on here, or you must willing to see an otherwise normal pulling back. Professor Regula told you already the rule of 7 minutes, and he is right about that. You should look very carefully on your way back. Take enough time. Another thing, they were talking about metal and blue. But if you look, for instance, to this scope, and you look here, the vessels, the whole thing, I think that what we needed in the future that much more staining is with now all the artificial intelligence in the scope, that you can look for small polyps with color enhancement and these sort of things is not a problem. You see in this patient, you see so beautiful, even the pits, everything is there. And also the very small polyps with this system you will see. But it's the whole thing. You see the valve here? I normally intubate the terminal ileum as a routine. That's what we ask for the fellows. Interestingly, now in the colon screening program, we don't do it anymore. Because what is the need of this in the patient population of 55, 75? Then it's difficult. It's different. In general, when we have the younger patients, we always do it. However, in the Netherlands, we now see that the general practitioners, to exclude serious pathology in young patients, and they think it's IBS, they already do calprotectin and tissue transglutaminase to rule out IBD and celiac disease. I give, I would say, back to the audience, and you go on with your program there. Okay, thank you for your attention. I think, yeah, and then we go back. Okay. We can do it, why not? The problem is, yeah, we can do it, but I mean for the audience, otherwise the program is running out too much in time. No. I worked in Japan for 3 weeks in several occasions. And in Japan, I have the feeling that the Japanese intubation is easier, but that's different. Now we leave it, there's no use for and the audience is now for the next speaker, so we can come back. I think, you speak English, huh? Oh. Talking about nurses, and if, of course, with the scope and rotating, you can do everything. But if in the Netherlands, what we are doing, if the nurse,
як критерій, і в яких випадках
when the nurses are
і
saying,
обов'язково чи
you
проводити
see a
біопсію, якщо
polyp,
слизова візуально
I go
незмінна.
back. So the nurse, both of us, and that's also the advantage if the nurse is joining me for this, and she must make decisions, polyp yes or no, and pull or push. The nurse, then you have, instead of 2 eyes, you have 4 eyes.
Professor Mulder, 2 questions from the audience.
Oh, let's have a look there. Let's have a look to that thing.
Chris.
Oh, the audience is still looking. Oh, sorry, I wasn't realizing that you were still looking.
Please repeat the questions one more time.
Yaroslav, Prof. Regula, or would you remove this one as a cold snare?
Yes.
Would you would do that?
Microphone, дайте.
Do you think this is a polyp?
I'm not sure, but I think it is a polyp, so I would remove it. Cold snare.
Okay, so I would do it the same, but I think
is
that
it really an
if
adenoma?
people in the audience,
Do you think
What?
it's definitely an adenoma? You should confirm.
no, I'm not sure. For sure.
Yeah.
So that was the reason
Chris.
why I was asking the audience.
Can you use
What we see
NBI?
in the adenoma detection rate, that of course if people start to do this as a routine, the adenoma detection rate will be higher. What we are now discussing in the Netherlands is it really benefiting if a patient is already on risk and is on a fixed follow-up? Let's say if you would have seen in this colonoscopy 2 or 3 larger polyps, and you would know that you would see this patient back in 3 years, is it mandatory to do it in all of them? I think in this case I'll do it. But the discussion is, will we do it in the future? We don't know yet. For the quality of the endoscopist, it's good to mention this as a polyp and to exclude that's an adenoma. But a lot of doctors now in the Netherlands are talking about this. Does it make sense if the patients come back in 3 years to remove this sort of things? We don't know yet. Okay, a polyp, snare, cold snare, yeah. The other thing is, if you do a cold snare in these sort of cases, you have to put this under the microscope. The thing is, in a clean colon like this, you will have access to this to remove it properly.
Chris, there is a suggestion from Professor Kashida to use NBI, near focus, to try to find the optical diagnosis of this polyp, maybe.
Yes.
NBI and near focus, maybe we can have a look.
A little bit. If you look like this, I personally doubt, but okay. What do you think? No, I think, yeah, but
could be.
I think it's hypoplastic.
Yeah.
What do you think there?
I agree. It doesn't look like an adenoma.
Yeah. Okay. Okay. Open. So the question is now also in the Netherlands we start. Close it very. Yeah, sorry. Close. Excellent. Close it. Got it. So what I prefer now is also, I didn't do it here, but normally I bring the polyp to the opening, to the some water, yes. But I think it's there already. I bring in too much water, sorry. That's also, sorry. That's also the interesting thing of a live demonstration, is that's different than back home. But okay, it looks we removed it and it's in there. Yeah, we harvested it. So we have now realized, and I do agree with both seniors in the audience there, that this was probably hypoplastic, but even without narrow band, without advanced coloring, I thought this already. Okay, so we have to come back very slowly and rotate and look properly what we are seeing. One moment, we have to inflate a little bit more.
Chris, 2 questions from the audience. First, it is
yes.
In your routine practice, do you do cecal intubation always? And
cecal, yes, cecal for sure.
Ileum intubation. Oh, sorry, ileum intubation.
Oh, ileum. I was talking in the screening colonoscopies in patients above the age of 55 who come for the screening. We do it less and less. That's time consuming. It depends. You can predict normally, when you're quite experienced, which patients you will intubate within seconds and which patients will take more time. So in general, with all patients below the age of 50 who come for unexplainable pain, some inflammation things. We want to know if the terminal ileum is good. Then you have in Japan, those multiple strictures, abnormalities in the terminal ileum. So it depends also on the culture. For instance, I've been several times in India with in the leading centers, not only Neki Reddy, he is probably the most famous endoscopist from India, but you have, let's say, 10, 20 people like him, and they see quite a lot of intestinal tuberculosis. And intestinal tuberculosis is not only in the cecum, but it's also in, one moment we have to clean, that's also in the migrant population. So what we see at the moment in the Netherlands, we see not in the Iranians, but in the Syrian fugitives, in the Somali fugitives, we see intestinal tuberculosis. The Iranians fugitives are too rich. They were already in a very good social health system. We don't see that much of tuberculosis. So if we do colonoscopies in the migrant, sorry, I have to clean it a little bit. In the migrant population, we look better in terminal ileum intubation and do it as a routine. So we're not, sorry, there's some, can't have proper access. I want to inflate a little bit, but let's say in our second generation Turks and Moroccans, we have quite a lot of them. We treat them like Dutchmen, and there's not the need always to go into the terminal ileum. But in the training for the fellows, I focus to intubate. But then I have, let's say, 45 to 60 minutes and not 30 minutes or 20 minutes. So it depends. It depends on the goal of your endoscopy. It depends on the patient. It depends on the history. But I was telling you about nurse endoscopists. I have one nurse, and her name is Marlies. And Marlies is famous in our unit. Marlies will intubate everyone in terminal ileum, and normally within 10 seconds. And Marlies is our best intubator of the terminal ileum. We have to admit this.
Question.
I want to bring in some air, but
if you have a normal mucosa in the patient and patient have a clinic, do you take a biopsy?
In this patient, no. But in all patients with unexplained diarrhea and things, we take with a very low threshold biopsies in different places from the colon for collagenous colitis and micros. Sorry, I don't know why it's not opening very properly. Sorry, I have to clean and to bring in air, and it doesn't open very. So we have a very low threshold of taking biopsies in the colon. This is also one of the things described now by the English group, the underwater people. They think that if you have a clean colon and you do a colonoscopy like this, you will see the majority of polyps. I personally doubt. I'm not satisfied. But I'm not satisfied what's going on because I can't bring in much air in the scope at the moment. Sorry.
Okay.
Yeah.
Thank you, Chris, for your masterclass. We must leave you. Thank you for you and all team.
Okay, go on. And it's. I think the initiative today is a great initiative for colon cancer in Ukraine. My compliments.